Welcome to the School of Medicine ultrasound course. This is going to be our introductory lecture. This is going to be a kind of big lecture because we're going to talk about the course, introduction to ultrasound, and then we're also going to be jumping into our first topic, which is aorta and IVC. I'm Lainey. I'm one of your co-directors for this academic year. And we
All
have
right.
Dr. Singh on with us as well.
All right. Thanks, Lainey. I'm Suk. I'm the co-director as well. And yeah, let's get started.
All right. So first things first, this is just what we're going to talk about in our first part. And starting with the grading and course overview. Suk, do you want to go over this one?
Yeah, please. So this is ultrasound. Recently, probably the past 2 years, has become part of POM, and so we have to give POM a part of your grade. And so the ultrasound component is about 20% of your total POM grade. You're going to have a total of 4 sessions as MS1 in ultrasound. Those are the topics you see we're going to cover today, being aorta plus intro plus IVC. Today's kind of a beastly topic. It's going to be a little bit of a longer lecture, but the future lectures will be a lot shorter. It's longer because we're covering both how to teach you about ultrasound in general, plus an actual topic, which is aorta IVC. If you attend the topics, and attendance is mandatory, we're going to do quickly sign-ins during the session. And essentially, engagement and attendance is worth 2.5% of each in each session. After the session, you're going to also get a quiz. The quizzes are not going to be particularly challenging if you showed up to the session. If you don't show up to sessions, obviously it's going to be a lot more hard, a lot more challenging. But if you show up, it's really good kind of to reiterate and re-emphasize stuff we cover. And we'll give those quizzes about a week or so after the session. Essentially, that will encompass 20% total.
All right.
I, yeah, I should quickly mention just how it will work is you're going to be split into on a Wednesday 2 groups. You're going to be either POM in the morning, and by morning I mean 1 p.m. And then ultrasound simultaneously, and the groups will alternate around 2:45.
Perfect. And you guys can always email us if you have any questions or to clarify anything. So jumping into our introductory things, we're going to start talking about hardware because you can't do ultrasound without an ultrasound machine. There are many, many, many different types of ultrasound machines, but the big takeaway from this slide is that there are going to be different probes that attach to machines that you can use. Most of the classical machines that we'll be using in our course and that you'll see in the hospital systems are going to have a different probe or multiple different probes attached to the machines, and the probe will be attached via a connector highlighted in that yellow box. But newer technologies and probe machines do exist that have what's called a universal probe, where you'll be able to switch between probe modes using the same piece of hardware. And I think we'll have some butterfly IQs in various sessions for you all to play with too. Talking about different probes, why we care about having different probes, it goes back to a lot of physics that we're going to jump into, but essentially you'll have low frequency probes and high frequency probes. Lower frequency probes will allow you to see deeper into the human body at a lower resolution, whereas high frequency probes will give you that beautiful picture resolution, but then you won't be able to see as deep. And we'll explain why in just a little bit. When we talk about moving the probe, there are some cardinal movements. Sliding or translating is just kind of moving within a 2D plane, rotation clockwise or counterclockwise. Tilting, otherwise called fanning sometimes, because you're moving the probe the way that you would move like a fan to fan yourself. And then rocking is essentially like fanning on the short axis There's another movement that is not pictured here, and that's compression. And for certain structures, you might want to add an element of compression to help distinguish what you're looking at.
Yeah, and a lot of these movements will become very intuitive quickly.
Yes.
Yeah.
All right. On each probe, there should be what's called a probe marker, and it can take various different forms and it can be tricky. Sometimes it's the classical dot, sometimes it's a raised sort of line or nick, and sometimes it's actually sunken. So it's always helpful to identify which one is the probe marker, and then how it correlates on your screen. So this arrow is pointing to the probe marker on this sort of image. And I'm assuming this image is produced by a GE machine, because a lot of times the machine will actually use their brand or logo as the probe marker, whereas others will just use a classic little circle as their probe marker dot. All right, and let's jump into the fun stuff. Some physics review, hopefully not as painful as it was in undergrad. So we have what's called the piezoelectric effect, and that's essentially how we can have ultrasound machines and probes. We have a very special piezoelectric crystal, which was invented specifically to vibrate and create ultrasound waves at the frequency that we want to be able to see images. Probes can create these waves and also read and interpret the reflection of these waves to generate your ultrasound image. And depending, again, on your probe selection, you'll either create high frequency waves or low frequency waves. And so you'll see on the right side of the screen, the low frequency waves with a longer wavelength will allow you to see deeper into a structure as opposed to those high frequency waves on the left side.
And here you can tell, also the resolution thing. So if you see these waves, going in and out of the axis so quickly, you get a lot more data information. And if the waves, basically pass through the information, you might skip something. The most intuitive way to think about it when you start scanning is whenever you're doing anything in the body, the chest, abdomen, pelvis, anything like that, you're gonna want the low frequency wave because you got to look deeper. And anything you're doing in the arms, in the neck, in the head, in the legs, you're going to want the high frequency probe.
Yep. And then it also kind of matters what structures and what parts of the body that you're looking at. Parts of the body that have more water content and that are more dense will allow for better sound transmission, whereas parts of the body that might have air in it are pretty much not going to transmit sound waves, and air is sort of the enemy of your ultrasound waves. So trying to avoid the spaces where there is air is going to benefit you in actually being able to see in and around structures.
The example I to give students, the example I to give students with air is like talking in space. You can't talk in space, basically because the signal is lost. There's no return signal. With ultrasound, the waves are a lot higher frequency than our volume that we talk in. And so essentially when there's any kind of air interface, there's just no return signal. The signal completely scatters, nothing return, and you get zero transmission.
Yep. Same thing goes for the flexibility of the structure that you're choosing. Let's say you've avoided all the air, but structures that are a little bit more flexible or squishy are going to allow for better sound transmission, like your organs, like your liver. Whereas if you're going up against something that's pretty solid and rigid, like a bone, it's not really going to be able to transmit sound waves.
Yeah. Take away two enemies of ultrasound: bone and air.
Yep. All right. So this is probably intuitively obvious, but just to kind of speak it into the world, attenuation, your ultrasound waves are going to lose strength with each type of tissue it passes through. So the more different interfaces, if you're going from a flexible organ to a non-flexible organ, through air, through et cetera, your ultrasound waves are going to get weaker and weaker, and you're not going to be able to see as much. So trying to get through the most homogeneous type of structure is going to help. As mentioned before, if you have some particles that are of varying different makeup, the ultrasound waves will scatter when they hit it. And this is going to lead to some artifacts that we can see, and we'll talk about later. But just a note, again, looking for structures that are more homogeneous, more able of the same density and flexibility. Otherwise, you're going to get a lot of scattering and diffusion of your ultrasound waves. All right, and then reflection. Your sound will lose strength as it gets reflected back to the transducer, and then that will create your ultrasound image. And this can also lead to an artifact that is generated by certain types of tissues and structures within the body. So just know that reflection is a part of physics, and it does lead to an artifact that you'll have to think about and interpret when you're looking at your ultrasound image. Refraction is not talked about as much, but this does happen. Sound will change direction when it passes from one medium to another, sort of that prism effect that you might have learned in physics long ago. And we sort of have that with sound instead of with light in the body with ultrasound waves. And this can also lead to different artifacts that you'll see on your ultrasound screen. So let's talk a little bit about how do we get the best images. A quick note on how to talk about what you're seeing on your screen. Most of ultrasound is in black and white and grayscale. So are you going to talk about the whiter part of the image or the blacker part of the image? We actually have terms to describe this. So if things are brighter, they are hyperechoic. Versus darker, they're hypoechoic. If they're pretty much the same as everything around it, then it's isoechoic. And then things that just don't reflect sound at all are anechoic. And those are some examples of what that looks like on the screen. Depth is a very important measurement and probably the first one that you'll mess with when you're looking with your ultrasound probe. And you want to center whatever structure you're looking at pretty much in the middle of the screen. So this would be way too much depth to analyze that vessel right here at the top of your screen, whereas this would be not enough depth because it's getting towards the bottom of what you're seeing. So somewhere in the middle of your screen is going to be ideal. And we call that area your focus zone. Okay.
Yeah. The big takeaway when you're scanning is whatever you're interested in, just put in the middle of your screen.
Perfect. And then gain. Gain is going to be essentially how bright or how dark your image looks on ultrasound. So if you put your ultrasound probe on and this is what you see, it's probably undergained because it's not bright enough to distinguish the structures that you're interested in. This is actually going to be overgained. It's a little bit too bright. You're losing some resolution here. So you want to adjust your knob to be perfectly in the middle gained where you're able to see distinguishments between different tissues, types, and structures. To optimize your depth and gain, most ultrasound machines will have presets for the exam type that you're choosing. So if you're looking at the heart versus if you're looking at the abdomen, you can select the mode or the exam type on the machine, and it'll pre-select your depth and your gain with the frequency of probe that you select for that organ type, and then you can adjust afterwards. So that's a great shortcut to get to probably a close to ideal depth and gain. Important to know, is the freeze button, which takes various different forms depending on what machine you're using. I really like the freeze button because maybe you see something flash across the screen for just a split second and then you can't find it again. When you hit the freeze button, usually the machine has recorded 10 to 30 seconds before you hit the freeze button, and you should be able to cycle back and essentially rewind to find whatever it was that you were looking for.
Yeah,
Then
I liken that to
Mhm.
the iPhone live photos, which I know, Lainey, you're not familiar with because you use Android. Um, but I liken it to that, which is you take a photo, and when an iPhone, you can just always go back to it. The cine loop.
Yep. And then we have our capture or record button. Some machines will have a separate sort of like camera capture versus video capture, whereas other machines will utilize the same button for both. When you have used the freeze button and you have a frozen image on your screen and you click the capture record button, it should save just that one frame. Whereas if you're live scanning and then you hit the capture record button, the usual default is to capture 4 to 6 seconds from when you hit that button, what they're seeing on the screen. If you really want, you can change the length of the clip and you can actually capture in retrograde. But I don't think we're going to need to use that at all during this course.
Mm,
But it's just so that you
mm,
know if you want to play around with it.
yeah.
All right, let's talk about different modes of ultrasound. Your classic default mode will be B mode, aka brightness mode. Most of the people will say B mode or just default. And this is your regular ultrasound mode, and you can make all the adjustments that we talked about earlier. Then you have what's called M mode. You should see a button that says M or M mode on the ultrasound machine. And that stands for movement mode. And so when you see an image that's playing, when you hit M mode, the first time you'll get a little line across the screen, and you should be able to move that line over whatever area that you're interested in. And then when you hit that button one more time, you should get something that looks like this. And it's going to show everything along that line moving over time. And so that's going to help you really isolate different movements. And this is going to be helpful for different exams, especially on moving organs like the heart.
Yeah. So in that one, it's like the mitral valve is going up and down, and that's what you see. So on the x-axis is actually time. So it's the mitral valve moving over time. And so you can use stuff like this to tell when you're diastole or systole. Um, and there's a few unique uses to it. Won't use it that often, but definitely this is the time to learn about all these different modes.
Yep. All right, a quick note on the Doppler effect, which you might also remember from physics. The frequency changes when sound reflects off of a moving object, and you can use the Doppler effect to your benefit to determine direction, speed, and even like the pattern. There are 3 different types of Doppler that we usually see on ultrasound machines. The most common would be color Doppler, which will tell you direction. We can also use pulse wave Doppler, which will tell you speed over time and some patterns of flow, and then power Doppler, which will tell you the strength of flow. And we'll give you some examples here. This is color Doppler. Whenever you're selecting a Doppler mode, they'll give you a little box that you can move around the screen to highlight the area where you're interested in looking at flow. In color Doppler, any flow that's red is towards the probe and blue is away from the probe. So if you're looking for flow, you want to orient your probe in the actual direction of flow. If you're perpendicular to flow, you might not catch it. So here we're looking at flow in the heart. We're looking from the apex of the heart, and we're looking at blood as it's moving through different chambers of the heart. Cool. Then we have power Doppler, and this is not directional. This is just strength of flow. And this will help you pick up smaller, less strong flows. Here we're looking at a kidney, and we're looking at the vasculature flowing through a kidney. So it's just more yellow if it's like a stronger flow, and then more red if it's like a weaker flow. And then lastly, we have pulse wave Doppler, which in addition to that box that you have to select and move across the screen, there's actually going to be what's called a sampling gate. Some people call it the equal sign. I like to call it the hamburger. However you want to call it, you have a sampling gate and you actually want to adjust that in addition to the box that you're moving across the screen to look for flow right at that area. And so when you put your sampling gate, any flow towards the probe is going to give you an upwards deflection of your pulse wave, versus away from the probe is going to be a downward deflection. And so when you get your waveform, it's going to look like this for flow towards and away from the probe. And that's how you can look at different patterns of flow.
Yeah, and unlike color, now you actually have speed too, right? And that's what the pulse wave Doppler gives you. So you can see kind of on the y-axis, those are your kind of your centimeters per second. So you can actually see how fast the blood is flowing. Versus color, it just shows you it'll be red, 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 but it can't actually tell you how fast it's going.
Yeah. This has a lot of applications in cardiology when we care about that blood flow, stroke volume, etc. Okay, so let's talk about those artifacts that we've been alluding to in our physics part. Our first and probably most easily identifiable artifact is going to be the mirroring artifact. And this is what happens when your ultrasound waves hit a very reflective surface right next to some air, which can't go through. So this is classically going to be found in your pericardium or in your diaphragm. And in this image, you have an actual heart kind of closer to the surface or the top of the screen, and what looks like almost a second heart beating in perfect unison with the other one. No, that is not a second heart. That is a mirroring artifact from the ultrasound waves hitting the pericardium. Then we have shadowing artifact. This occurs when your ultrasound waves hit a structure with high attenuation, aka you can't really penetrate through. So like we talked about, any structure that is very rigid and not flexible will cause a sort of shadowing artifact. So bone calcifications. In this case, you're seeing the shadowing from individual gallstones inside a gallbladder. So those stones are calcified, and so the ultrasound waves are not able to see directly behind them. Posterior acoustic enhancement is one of the more subtle artifacts that most people don't think about because it gets lost in a lot of the other structures, but it's important to consider. And this happens when ultrasound waves pass a structure with significantly low attenuation. So you're able to see well through it. These are your very flexible structures, your structures with a lot of water or fluid, like blood. And in this case, the ultrasound waves, they kind of accelerate through that fluid because it likes traveling through that, and then it hits the back wall of whatever's holding that structure or fluid, and then you get this kind of scattering of waves, and it causes the wall of that structure to look a lot thicker and bigger than it actually is. So in this case, you're looking at a bladder, and the back wall of the bladder is sort of lost into a bunch of like whitish grayscale, and it's not as clear as the wall towards the top of your screen. And that's due to your posterior acoustic enhancement artifact.
Right. Because the machine thinks as the signal goes further and further and further, you've lost signal. So it'll make things brighter the deeper it goes. But when you go through something cystic, fluid filled like this, the machine essentially overexposes it because it makes it too bright. So it doesn't know that you didn't lose any signal.
All right. Edge artifact is a fun one. This one happens when your ultrasound waves are refracted off a smooth or curved structure. So you're not able to make that perfect bouncing off of like a more straight or flat structure. It's as your ultrasound waves are hitting the edge of that curve, and it causes a shadow-like line that comes out off of the edge of these structures. So I've highlighted that here in red. So you have your ultrasound waves hitting this curved vessel structure, and right at the edge of the curve, as your ultrasound waves are hitting that and kind of refracting off, you're going to get this shadowing, and that's called edge artifact. Then we have reverberation artifact. This happens it's almost like extra reflection or mirroring. It's basically you have a lot of very reflective surfaces that are bouncing your ultrasound waves back and forth between the reflective surface and the ultrasound probe. And the ultrasound probe interprets that as multiple different structures, when in reality, it's just that one structure. Our classic example is here looking at the surface of the lung. You can see the pleura is highlighted here, and your ultrasound waves are gonna go through that sort of subcutaneous tissue and that muscle. And as soon as it hits the surface of that pleura, it's gonna start bouncing back. You're not actually gonna be able to see into the lung because it's full of air. But it's going to look like you've got multiple levels of pleura repeated down your screen, and that is called reverberation artifact.
Yeah, and it really is just mirroring, right? And then you can actually, if you look at it, all these reverberations are equally spaced out from the top one. So once it first bounces back, that gives you your first pleural line. But a second bounce back gives you your second your first reverberation, or your second line. A third bounce back gives you a fainter one. And if you increase the depth more, you'll see a fourth one and a fifth one and a sixth one. And they're all equally spaced out because every single time it bounces back, machine doesn't realize it's the same signal going back and forth. It just thinks, oh, I've traveled this distance again and again and again.
Exactly. Fun fact, when we get to our lung section, these are called your A lines on your lung ultrasound. All right, our last artifact is going to be our comet tail artifact. Sorry for the quality of this image, but this happens when you have two reflective surfaces really, really close together. And so those ultrasound waves reverberate between the two. And so you see those reverberations go down, but very, very closely spaced together. So this is supposed to be a needle going into a vessel. And so if you think about a needle, you've got reflective surfaces on the outside of the needle and a tiny bit of presumably fluid as it's going into this vessel between the needle. And so that's causing very, very closely spaced reverberation artifact, leading to this kind of comet tail look coming down. All right, I think we're done with artifacts and physics and all that stuff. So we can jump into our first topic of aorta and IVC. Take a deep breath, take a sip of whatever you're drinking, and let's do this.
Coffee. There you go.
Or coffee, yeah.
There it is. Mischief managed.
Oh, I have one of those cups too. I love them. All right, so we're going to talk about some anatomy, some techniques, and then the views that we're going to care about. We're going to kind of talk through how to get all of these, and then you guys will actually get to practice this during your lab. So the anatomy of the aorta, it's a very long structure. It's divided into multiple parts. You have your thoracic part, and then within your abdominal aorta, you have your proximal, your mid, and your distal, and then your aorta bifurcates into your iliac arteries. So we're going to talk about how to look at mostly our abdominal aorta today.
Right.
Big tip.
I'll just mention.
Oh,
No, yeah, you're right. We're going to look at abdominal aorta today because this is why the physics lecture is important. You can't see your thoracic aorta. It's behind the lungs. And as we talked about, you can't scan through lungs. There's some tricks you can do, but in general, you have the lungs in your way, so you can't see it. But in the abdomen, right, there's theoretically less air. so you can see it. However, there is still some air, which is bowel gas. So if you have bowel running over it, you're not going to be able to see it. That leads, I think, to your tip.
Yes, firm, steady pressure, and you all will probably be surprised to learn during your hands-on lab just how much pressure you might need to apply to really see the aorta, depending on what that person has eaten recently and how much bowel gas they might have. So remember that, and we'll practice it, and you'll see how much firm pressure we'll need. Starting with our subcostal view. This is going to be all the way up in the very top part of your abdomen. And this is going to be the best way to sort of see your IVC coming in and connecting to your heart. So illustrated on the screen, we've labeled our right atrium and our IVC. And we'll talk about the probe positioning a little bit more in the lab, but you want your probe marker almost essentially pointing towards like the spine or the back of the bed. A lot of times it's discussed as pointing towards the feet, but you actually want to point towards the feet and then kind of like rock a little bit to point towards the back of the bed so that you can point up towards the heart.
Yeah, and a lot of this will become a lot easier once we actually start scanning.
Okay. And then in our transverse view, this is when we're going to identify the difference between the aorta and the IVC. The first thing I recommend people look for is the spine shadow of your vertebral body. That will be nice and bright because it's a bony structure that ultrasound waves won't be able to penetrate through. Superficial to that, there should be two dark hypoechogenic structures, and those are going to be vasculature. One will be the aorta, one will be the IVC. In people with normal anatomy, the aorta will be on the patient's left and the IVC will be on the patient's right. You can confirm which one is which by applying some compression that we alluded to earlier. The IVC should compress, the aorta should not. You can also use pulse wave Doppler to look at the pattern of flow, and you should get pulsatile flow through the aorta versus continuous venous flow through the IVC.
Right, and just to give you guys an idea, so you're putting the probe right here firmly. The probe indicator goes to the patient's right, and you push really firmly, and that's how you're going to get this view. And then you pretty much just drag that down to get the rest of the aorta, but you push firmly. Lainey, it's funny you mentioned it, like in normal anatomy. I've only seen this once, and it was in a medical student, this normal variant, but his aorta and IVC midway through flipped and reversed.
Wow.
And yeah, and I was like, I've never seen that before. And the whole time I kept thinking that I have the probe backwards. But it happens.
So yeah, maybe we'll find someone else with a abnormal anatomy during our lab. All right. If you're going to measure the aorta, make sure to measure from the outer wall to the outer wall. And anything over 3 centimeters is considered an aneurysm.
Yeah, and then today during the session, we're going to practice hitting freeze and actually measuring to kind of teach you how to do this.
Exactly. All right, then the first level of our proximal aorta, we are going to look for what's called the celiac trunk. It should be branching off superficial to the aorta, so it should go up towards the top of your screen. It should split into the splenic artery and the common hepatic artery. And if you get it at just the right angle, it's supposed to look like a seagull, aka the seagull sign. And that's going to be one of the first structures that we try to identify.
Yeah, and it's hard. Often if the transverse colon is going right above this, you're going to get a lot of bowel gas and you won't see it, and that's okay. But just knowing that this is the first branch in the abdominal aorta is what's important. And just knowing that it's way up here, it's very proximal, and you got to push firmly to see it.
All right, and then in our mid aorta, even though it's classically described as like a different part of the aorta, they're very close together. You don't have to move very far often from your celiac trunk to identify your superior mesenteric artery. Again, it's going to come off superficial to the aorta. And as long as you're not adding too much pressure, you should be able to see the left renal vein traversing between the two.
Right. And then you're literally just kind of sliding down a centimeter or two. So all we're doing, once you kind of get into that position, just slide down until you get to, the next phases. Eventually you'll get to the bifurcation.
All right. And then our distal aorta, this is going to be a lot further down, usually around the area of the umbilicus or your belly button. And you want to follow that aorta as you scan down, holding that firm, steady pressure until you see the aorta split into two different vessels. And so that's what this clip up here is demonstrating. You have your aorta and then it's bifurcating into your two iliacs. And this is a frozen picture of what the two iliacs look like. You should measure each one as well, and your normal is going to be less than 1.5 centimeters. So the way I like to remember it is if your aorta normal is 3 centimeters and you cut it in half, then you get 1.5 each.
Yep.
All right. And then lastly, let's talk about our longitudinal view. Everything we've been talking about so far has been in our transverse view, sliding down, but then you can rotate to identify your aorta in long axis, and you can actually see both the celiac trunk and the superior mesenteric artery branching off superficially if you're able to get it at just that right angle. This is also a good view to try to identify any saccular aneurysms that you might miss on the transverse view as you're coming down.
What's a saccular aneurysm?
Oh, we're going to talk about that. So we've got, so talking about aneurysms in general, most abdominal aortic aneurysms are going to be below the level of the renal arteries. And the two types of aneurysms that we can identify are either fusiform, where it's almost like the whole aorta is nice and big, whereas a saccular aneurysm will be like a little outpouching from the side of the aorta. And this might be missed on the transverse view as you're coming down, and that's why the longitudinal view is nice to kind of look at the aorta as it's coming down and see if you've got any like little bubbles or side areas coming off of the aorta that you want to catch. And here's just a clip of measuring the aorta from outer wall to outer wall. So identifying that hyperechogenic outer wall, even though the hypoechogenic inside where the actual fluid and blood is flowing is much smaller. And then all of this around that is clot, dissection, etc. Cool. And I think that's all we have.
Oh, nice.
Yeah.
That was a little bit long. I get it. In the future, these sessions are going to be a lot shorter because it's going to be just like the topic we covered, which is Aorta IVC today. We want to go over the intro with y'all. I think we're going to have a fun session. During your hands-on, we'll give you a checklist, right? And your faculty will have one as well. And then essentially it covers everything we just talked about. And so your goal should be at the end of your session to just make sure you understand all these topics. I know this is a lot of information in the video, but once you have this, 2 hours of hands-on to kind of reemphasize this scan, I think it's going to really congeal it together. But go over your gain, your depth, talk about your artifacts, ask your faculty, and then all you're really responsible for today is just scanning the abdominal aorta, just this much.
All right.
Any other takeaways, or that's it?
I think that's it. We're both very excited to start this year with you all and to get some hands-on time in the lab scanning.
Yeah, have fun, guys. Please feel free to shoot us emails if you have any questions. And happy scanning.
Yay.